Welcome back for more anatomy and physiology. We're going to deal with the heart and in particular its electrical activity. So we're going to deal with reading action potentials of the heart. So a little bit of review. All muscles contract, and in order for them to contract, what we get is a neurotransmitter that gets released from a neuron across the synapse, binds to a receptor, triggers a depolarization. The result of that depolarization, of course, is a muscle contraction. Smooth muscle and cardiac muscle, on the other hand, don't necessarily need that. They actually have autonomic innervation, meaning they have nerves from the autonomic nervous system, and what those do is they allow for massaging of what happens, but it's not exact control, because smooth muscle and cardiac muscle can contract on their own. Again, like I already said, they all can depolarize. When they depolarize, we release calcium ions. Calcium ions bind to the thin filaments, which allow for the thin filaments and the thick filaments in order to form cross bridges, which will then cause an action or a power stroke, thus shortening the muscle. When we look at smooth muscle and cardiac muscle, as I have also said, we notice that they can depolarize on their own, and part of that is due to a random influx of calcium ions. Smooth muscle and cardiac muscle also have the benefit of having things that we call gap junctions, which are cytoplasmic extensions or connectors between adjacent cells, meaning we can have a chemical synapse, or probably not a chemical synapse, but an electrical synapse where one cell will tell the other cell what to do. The result of that is the cells will function in connection, or what we would call a functional syncytium. Also, when I look at cardiac muscle cells, there's a kind of a cap when I look at its depolarization. And if I look between the depolarization and the repolarization, there's a pause in between the two. That pause, called a plateau, is due to the presence of calcium ions. And obviously, they have different functions. So, if I look at the heart, it obviously is going to contract. Part of it that contracts first is what we call the SA node or the sinoatrial node, and it is the fastest one to contract. Thus, it is referred to as the pacemaker. It will depolarize once every second or so. That depolarization is going to travel. Part of it's going to cause muscle cells to contract, but other cells that aren't as good at contracting are what we call conducting cells, and they have different names like Bachman's bundle and things like that, are going to also send that depolarization from the SA node to the next point called the atrioventricular or AV node. As that signal moves from the SA node to the AV node, the result is the atria will contract or they will undergo atrial systole. From there, the signal will go from the atrioventricular node, the AV node, down the interventricular septum through what we call the bundle of His and the bundles, branches, go to the apex of the heart, and bounce up along the ventricles, along what we call the Purkinje fibers, and the result of that is the ventricles will contract. Since the heart is a functional syncytium, we will notice that if we start contracting on the left side, the wave will go from the left side to the right side. It doesn't happen all at once, but we get a smooth motion. What does that look like? This. There's the SA node. It depolarizes, sends a signal out to the AV node. Turns out there's a little pause in there. The result is the atria will contract. From that pause, depolarization will leave the atrioventricular node, pass through the bundles through that interventricular septum, and then as that signal moves down towards the apex of the heart, it'll move back up through the Purkinje fibers along the walls of the ventricles, and as it moves up, it will result in the ventricles contracting, or ventricular systole. If we make it so they contract, this is what we see. Notice how they also had valves opening and closing, which is also really nice, and we're going to deal with that later. We can record this in something that we call an ECG, an electrocardiogram, and that turns out to have a few components. This in particular is what we would call a 12-lead ECG, meaning not all ECGs are going to look like this. In class, we did a 3-lead ECG and it was nothing close to what this looks like. What we get is we have that first bit, that first speed bump, and we call that the P wave. The P wave corresponds with atrial systole, when the atria contract. The QRS complex is two things at once, which is why it's complex. It's going to deal with when the atria relax or have atrial diastole, and when the ventricles contract or have ventricular systole. All of that combined makes that QRS spike. The T wave, which is the last part of the ECG, turns out to correlate with when the ventricles relax or when there's ventricular diastole. We can use the ECG to record pulse, which is heart rate as well. Because if you look at the figures on the right, what we turn out to get are those little horizontal or those vertical lines. Those are time markers. So what I could do is measure from one point to the adjacent point. So like the R of the QRS complex to the R of the QRS complex. If I know how long that is, I have how long it takes for the heart to beat. And then if you do a little bit of simple algebra, you can solve for how many beats there turn out to be in a minute. It's relatively simple math. What does it look like all put together? Looks like this. So what we'll get is P wave, atrial contraction, from there, we'll end up getting from that atrial systole, blood enters into the ventricles. The ventricles are then going to contract and the atria are going to relax. When that happens, we get what we call the QRS complex. They're just showing little segments of how you read an ECG. So now we're going to get the QRS complex. The result of the QRS complex is going to be the ventricles deplete themselves of blood, and they're going to squirt blood out of the ventricles and into the arteries, the pulmonary artery and the aorta. At some point. Then the last bit, which is the T wave, would be when the ventricle relaxes. And what's actually not shown here is blood actually starts to fill into the ventricles. But then we can put it all together. We can't control your heart rate, but we can influence it. And the reason why we can do that is there are reflexes that are involved. We have innervation. So if we happen to do some special little tricks, we can actually start to influence the rate of your heart. One of the ways that we could do that is changing how you breathe. One of the ways that we can do that is what you think. So it turns out breathing and thought can influence your heart rate. So we can't necessarily control it, but if you train your brain, you can train your heart.